Then click this, share.
Yes,
Yeah,
got
that's
it. Yes, please start, Joe.
Perfect. See, you know what? See, we're all smarter than the average bears. There, now it's perfect. Okay, and then I can
yeah.
slide this over. Now I can see everyone. Well, first of all, welcome to everyone. I have to tell you, if I may, before I get started on this lecture, that you guys are so incredibly blessed to have Ejaz as someone who is willing to do all the work it takes to put all of this together. Now, Ejaz, with that said, I know that it takes a village. It takes a lot of people to put on any kind of a program. So, notwithstanding that, of course, you are who reached out to me, and you're who I know. But I want to also compliment everyone that has helped you through this process, whether that be your lovely wife, your lovely daughter, all of your colleagues. And I'm incredibly humbled that you would want me to be giving a lecture at such an esteemed meeting as what you're putting on here. And I'm so incredibly proud of you for putting all of this effort into this kind of educational platform, because it is so incredibly important for us to, one, learn from each other, but also developing the collegial relationships which will endure for a lifetime. And these are so important, and it's really what matters in this world. So, Ejaz, please accept my dearest compliments for your efforts.
Thank you so much. We pleased and we are honored that you give us such nice comments, and it make us more energetic and more motivational. Uh,
Well, this is important. This is important stuff. My lecture, of course, is scientific, and it's regarding a process that we'll discuss sort of why that is what it is. But ultimately, it's the process of putting the lecture together and getting it disseminated the way you have created this meeting today, and what you've been doing overall with all your book of perfusion and just everything that you're doing. That's really what is important. The one lecture is about one thing, and it's just a teeny little slice of a great big giant topic, and that's almost every topic we deal with, right? But we just learn by having these little teeny pieces come at us, and then we develop things and we share things. Our experiences are probably the number one most important thing any of us can share, is our actual experiences, because you can do all the randomized control trials you want. If every time you do X, Y happens, well, you know what? We all need to know that, because that's probably happening to all of us too. So, with that said, we're going to talk about normothermic regional perfusion, also known as NRP for short. And if anyone is having issues with my English, talking too fast, please, Ejaz, tell them to let you know, and you can just tell me that I need to either slow down or recover something, okay?
Joe, you are going very perfect, fine, very clear, good
Very,
English.
very
Totally,
good.
we are getting very clearly. Thank you.
Thank you so much. So, let's see. There. So, if you look at this map and all of the dots on it, this is, of course, the United States. My references are more going to be in the United States because that's where I work and where I live. But this is common throughout the globe. But you see all of those dots, and all of those dots represent an organ procurement agency's region of operations. And within each of those dots, there are patients who need transplants. They're on the transplant list. And what's important to take away from this is that when somebody says a patient is on the top of the list, or they're first on the list, well, every single one of those dots has somebody who is first on their list. And then it goes in numerical order from that. So first priority, second, third, fourth, fifth, that all the way, just keep going down the line. So when an organ becomes available, there's a whole bunch of things that have to happen. And that has to do with, of course, typing. And then once you find a perfect match, you have to take into consideration, is this perfect match close enough for us to get this organ to them safely? And if they're not, any of these things that happen, whether it's in typing and cross-matching, organ compatibility, time it's going to take to get it there, then that first person on that list may not be who gets that organ. It might be, when it's all said and done, the 17th person on some other, in one of these other dots. And so it's very important to take this into consideration when we think about who is really first on a transplant list and what does that mean. So I hope that made sense. So if we look here at this chart, and I hope you can see my pointer, I think, or not pointer, whatever this thing is called, arrow.
Yeah, we got it.
You look here at the various years, 2019 through 2025, and 2025 is right here. And this is all transplants, all organs, year to date. But you can see that from the 2019 area up to the 23, 24, 25, that the number of transplants being done is in fact growing. And it looks like this is still going to be on this increased trajectory. And there's a reason for that, which we will discuss as we continue with this lecture. When you just break it down to livers, for example, living donor transplants, which is mostly going to be liver, kidney. Of course, you can't do heart, but they do livers and kidneys. You see here that is also growing quite a bit. And here is the trajectory over here for this. Now, if you look here at this green line, you see what happened to my pointer. There it is. You look here at this green line. Can anybody on the call tell me why you think this line went down like this? 2020? What do you think the cause of that was? Correct, COVID. That is correct. And then when you look at deceased donor transplants, these are DBDs, patients who have been declared brain dead. You see the same thing that you see up here, the same basic trajectory. This is the overwhelming majority of transplants that are done. The living donors, you can see, they're pretty high. They're a little over 6,000. But compare that to 40,000, and it's a small sliver, right? Now, I don't know where that red line came from, Ijaz. Do you know? Do you know where that red line came from?
In the
right here. Like, I didn't draw it, so I don't know where it came from.
I don't know. Even
maybe let me see.
Check from there.
Maybe it was me. It was. Oh my goodness. Geez, I didn't even know I did that. Okay, let me go back to that.
No, it's
okay.
Good. Yeah.
It was me. Okay, I needed to get rid of that. So sorry. Please forgive me. Now I need to move this out of the way if I can. If we look here, we see the patients on the waiting list by organ, and this was as of last year, September of 2024. The numbers are quite similar for this year. Kidney, the highest, almost 90,000. 90,000 patients sit on the waiting list here in the United States for a kidney. Liver's pretty high. It's about almost at 9,500. Pancreas, a little lower. Kidney pancreas combination, which is not an unusual thing for us to see, a little higher than just pancreas, about 2,100, 2,200. Hearts, there are 3,400 people currently on our waiting list as of that date. Again, right now it's about the same. Lungs, 898, and then other, which includes faces and various different tissues. So we're just going to leave the other alone for right now because it's really not something that we deal with. But you can see here, kidneys 86%, livers 9%, the heart is 3%. Now, if we look at transplants that were performed through 2023, which preceded this last slide, you can see they did 27,000 kidney transplants, 10,000 livers, 4,500 hearts, 3,000 lungs. And this is our number here. Now, what you may notice is you go, wait a minute, there's more hearts that were transplanted than there are people on the list. Well, no, not exactly, because this only goes through September, 3,500. Okay, 4,500 hearts. This was in 2023. This is a full year. Okay. So here are some facts about here in the United States. There are greater than in total for every organ, all organs, over 104,000 patients actively on the waiting list. 13 of those patients die every day. But that does not include an even higher number that are delisted. And you can be delisted for a variety of reasons, including you no longer are going to have survivability. You're not going to make it. So they're taking you off the transplant list. You waited too long. You're not dead yet, so you don't go into the 13 people dying, but you get delisted and then you die off the list. But there's actually more of those people than there are people that literally die on the list. So this number appears a lot smaller, though 13 people every day is quite a bit when you add them up, but it's really triple that. And there were a greater than 48,000 transplants, which we saw earlier, performed in 2024. So ultimately, there needs to be an increase in available organs to keep up with the demand, because fundamentally, that is the reason why those people are dying on the transplant list and or being delisted and then dying. It has to do with organ availability. It's not the only thing, though it's the biggest thing. Managing organ storage is another thing, and we'll talk a little bit about that as we go forward with this. So here are some terms that you need to know. DBD is donation after brain death. And of course, we all know, I'm just going to go through it very quickly. Patients declared brain dead. They're brought to they get the consents. They're brought to the operating room. They're given comfort medicines, even though they're brain dead, and they're opened up. The organs, the heart's clamped, the liver's clamped, everything's clamped. The organs are removed, they're explanted, and everybody goes on their way. And then they close the shell up and send it to the funeral home. That's basically brain death. So the patient themselves essentially acts as their own normothermic regional perfusion, their own NRP, because their heart and lungs and everything else is still, all their organs are working. Everything's working pristinely in many cases. The only issue is they're brain dead. However, if they don't meet brain death criteria, then there has to be a mechanism by which we're able to allow that person to die. They're not brain dead, but they're not survivable. They're going to die once care is withdrawn, or it's believed they will. And that category of people are who fall into the DCD, which is donation after circulatory death. Now, sometimes you'll see it described as little c and then capital DCD, meaning controlled donation after circulatory death. But DCD, for the sake of this, you'll see it in papers, though, you'll see CDCD. And then NRP, normothermic regional perfusion, and OCS, which is an organ care system. Transmedics has been the originator of this from essentially a commercial use, but there's a new system out now called Organox for the liver. And I do believe they'll eventually move into the cardiac and the pulmonary space. But right now, Transmedics up in Massachusetts has the OCS system that is most well known and used here in the United States, and that's for heart, liver, or lungs. So it does those three organs. So what are the pros and cons of DCD, donation of circulatory death, versus OCS? And we're going to talk about the TransMedics device, but let's just talk about DCD. Well, the biggest pro is that it has, you're providing high quality organs that would have otherwise been discarded, because these patients are going to die, and they're going to die uncontrolled, and therefore their organs are going to be of no value, because they're going to go through a death process, and those organs are too damaged, and then you don't have the time to get them out and do a rapid recovery in typical, just normal static cold storage. So you're really in a situation where these organs are all just being thrown away, even though they are quite good organs. But the con to DCD is you have a sometimes significant warm ischemic time. We all know that's not good. Right now, based on early data, there doesn't seem to be a problem, but the data, we haven't been doing it long enough to really know what the rate of primary graft dysfunction, PGD, will be post-transplant, for how long, over 2 years, 4 years, 5 years, right? So unknown long-term risks. It is far more technically challenging than DBD, because there's a whole lot more stuff. And there's staffing issues that come into play, because with DBD, brain dead donors, you really don't need a perfusionist or anything like that. And DCD, you need not only a perfusionist, many times you need two perfusionists, but one perfusionist with an assistant who knows what they're doing could work, and works well for us. But there are still places here in the United States that do this with two perfusionists, because when it goes sideways, when the case becomes challenging, you really need the extra set of hands. It's a very short process, hyperdynamic, goes well when it goes well, goes horrible when it goes horrible. When it goes bad, it goes horrible. There's no middle ground. Here's an idea of some of the things that you would use. What you see here on the left is very typical. You're going to see this for every donation case. That's really not unusual to see most of these instruments, except you're not going to have these cannulas and ramels, and you'll still have suctions and stuff, but that's the difference over here. Over here, you're not going to have this with the DBD, with a brain dead patient. This is essentially what you're looking at, as an ECMO with a reservoir, because these patients are very hyper-anticoagulated. We give them 30,000 of units before care is withdrawn of heparin, and then we put 30,000 units of heparin in our prime. So these people are very anticoagulated. So you don't use an ECMO circuit. You use a mini CPB circuit, or a hybrid ECMO circuit that has a reservoir that you're going to be hooking up to vacuum, and all of your suctions are going to come in here. So you use a vacuum on this up to a negative 140 millimeters of mercury when you do these cases. But you see what I'm saying? This is an extra piece of hardware, and of course disposables, that you wouldn't have in brain death. And so you start increasing the complexity of these procedures. So what are the primary differences, however, of NRP to OCS? Kind of remembering back what I said with the pros and cons of DCD, one of the pros is, or the cons rather, was warm ischemia, right? But there's pros to it as well that you don't get with the OCS system, or the TransMedics system. When you do DCD, like we're talking about, it allows for in situ assessment of the organs. So these people die, and we're going to go through this process of how this all happens, transpires. But when they're dead, declared dead, and your standoff period has been met, and again, we'll talk about all of this, then you open them up and you hurriedly put them on that mini bypass circuit, and you start flowing. And there's a whole variety of drugs that we use. We call it voodoo juice because these are all intended to try and help the organs that have been ischemic and dying to recover from that process. And then once they have done that, you can actually look at the organs, the heart, the lungs, the liver, the pancreas, the kidneys, and assess them for functionality while they're still in the body, not having been removed at all. Whereas when you use the OCS or transmedics pump, and I'll use the heart as an example here, the heart is put in there, but the heart is never loaded. You can never fill the heart and actually assess the heart's functionality under load. You can do it with it being empty, and you can just look at it and see that it's beating and it looks good. But you have no idea if that heart is going to be able to tolerate a pressure at all, or how much volume it will be able to hold and before it will bog down and start to fail. Whereas with DCD, since the heart is still in the cavity, still working, you can wean them off bypass, essentially, see how the heart is working, really assess its functionality, go back on for a few minutes, and then you have confidence that heart is working really well. And when it gets to where it's going to, you put it in, it should work just fine. So you can't do that. Transmedics, it beats the whole way there, but then you take it off the machine and you put it in the patient, and then you fill the heart and it just distends and it doesn't want to squeeze, and you start using all these inotropes, and then all of a sudden you have a really crappy heart that you just transplanted in somebody, and you don't know that because it looked so good empty on the machine. And there's the big difference between the two. But on the other hand, there's a pro to it as well. There's an advantage to it. You have controlled coronary blood flow. You can measure the pressure in the coronary blood flow, or the coronary perfusion pressure, we'll call it, not the blood pressure. That's not what pressure here means. And you can measure lactates in that organ to make sure that the organ is not having any periods of ischemia during the transport of the organ. Now, a lot of people think, well, oh my God, that's incredible. It'll open up all these doors, and you could keep the heart on the pump for 10 hours. No, you can't do that either. What you're doing is you're increasing, and it's important. I'm not saying it's bad, but you're only really increasing the length of time that you can keep a heart going by about 2 hours, which can be significant. I'm not going to say that's not significant, but it is not something that's going to give you a day or two. Now, with the livers, you can put those on the OCS, and you can keep them overnight and do your liver transplants in the morning instead of having to do them in the middle of the night, which is historically what we used to do. But there's how that works. So there are pros and cons to both of these. And I think that both have a place, both have utility, and neither one of them really is better than the other, but one or the other may be better in each individual case, which should be assessed very carefully. Ex situ versus in situ. Well, of course, if it's distance, time, family consent, because some people find doing DCD with NRP to be ethically challenging for them. Organ reconditioning, risk factors, and the amount of resources being used. And then there's a 60, 90, 120-minute rule, which I will talk about now very briefly when you're talking about doing DCD versus DBD, or using the transmedics. So ex situ would be, of course, transmedics. In situ would be NRP, right? And that is when we go into a hospital here in the United States, each hospital will have their own set of rules. And they will say that from the time care is withdrawn from this person, this donor, you will either have 60 minutes, 90 minutes, or 120 minutes for them to die, meaning their heart stops. And if they don't within that time frame, we have to abandon it. So if it's 60 minutes, that's pretty short, but that does happen occasionally. And the patient dies at 61 minutes, we basically are done. We have to leave. If it's 120 minutes and they start dying at minute 100 or 90, and it takes them 30 minutes of being agonal before they finally do die, then those organs are going to be highly affected, much more affected. And we're going to have much more work to do in order to get those organs recovered sufficiently to be appropriate for transplant, or at least being able to be assessed for their suitability. When the patient doesn't die, obviously we have come there, we've traveled to God knows where, we've set all of this stuff up, thousands and thousands of dollars worth of equipment and supplies and drugs, and they don't die, and we have to throw everything away and walk away. Well, you can see here, there's an enormous cost to this. So they're trying to figure out ways, and I'm going to show you that, of how to determine whether or not we can better assess whether a patient will or won't die within whatever those time frames are. And we'll discuss that here. And keep in mind, when they don't die, it doesn't mean care is reestablished and we were just wrong. They weren't going to die and they're going to go home. These people don't have their care restarted. They're just taken to a hospice unit, and they're left there until they do die. They frequently die if they don't die within the 60, 90, or 120 minutes, they die that day. It's extremely rare that anyone would last much longer than that. These people are all dying. And here is a prediction model that you look at. They look at reflexes. They do a Glasgow Coma Score, GCS, obviously. Are they breathing over the vent, hemodynamic support, and their age? And so these things are filled out, and it gives you a value of what the probability is of this particular person dying within the time frame that you want. The problem is it's not very good. And they've done it this way, and then they've done it with just doing everybody. And the same percentage of patients don't die within the time frame, whether you do the prediction model or not. So if you just do all of them, or you try to narrow it down and do this, the exact same percentage of patients is what you actually do the NRP on. So it's not a very good model, but it's something that people are trying to work on. I did want to at least show it to you. And then when we look at this here regarding this particular study that we're going to talk about, which has to do with lungs, it gives you essentially what is the process. And it's the only reason that I picked this is because I thought this gave a very good idea of what this actually looks like. So you have a pre-withdrawal. So this is your DCD donor, your patient who is not brain dead and is going to be a donor. In the pre-withdrawal phase, we give not just comfort medicines, but an enormous amount of heparin, 30,000 units of heparin. Then care is withdrawn, and there's a period of time of that withdrawal phase. You then reach an agonal phase as this person is dying, and that can be any amount of time. You don't know what it'll be. Agonal, however, is usually considered a systolic blood pressure of below 50. Some are 70, and it depends on the hospital, the transplant service that is receiving the organ, what they want to know as the agonal, whether it's less than 70 or less than 50. And if it's less, whatever that number is, there's a certain amount of time that if it exceeds that, they don't want that organ because they don't think there's a way to reverse all of the injury that's going to take place. So once their heart stops and there's no longer a heartbeat, there's a declaration of death, and there is a standoff time. This standoff time can be anywhere between 5 minutes, which is most common here in the United States, to 20 minutes, which is more common in Italy. In fact, I think it's the law in Italy. So the standoff time can be quite a long period of time. And the reason for this is here, 5 minutes, is we all know no heartbeat, 4 minutes, you're dead, especially at normothermia, excuse me, your brain is dead. At that point, you are brain dead. But they add the extra minute, 5 minutes, plus you have to get in and get cannulated. That takes another 2 to 3 minutes. So really, you're about 8 to 10 minutes of no blood flow whatsoever. I don't think there's any question in anybody's mind that that patient's brain is dead. However, there's still, even with all of that, one more process that has to take place. So the standoff period ends. The heart has not auto-resuscitated. Death is recertified, and that becomes the actual official time of death. The chest is entered, and the donor, if it's going to be lung, in this case, you're reintubated, and various things are going to take place. If it's not lung, this part wouldn't happen. But what does happen on every case is a large clamp is applied to the arch vessel. Sometimes they use 2 clamps. The innominate and the right carotid and right subclavian arteries are all clamped to be sure we cannot perfuse the brain at all. But with that said, this whole period of time that you see here, all of this, no matter the organ, is functional warm ischemic time. And that is where all of the injury to the organs during the death process is going to take place. Now you have them on pump, and there's the reanimation phase, NRP interval. And this can be a variety of times. It depends on which organs you're looking for, how long the agonal period was. There's a variety of different reasons why it may be shorter or longer. But we're measuring labs, especially lactates, liver enzymes, looking for urine production, amylase, all of the things that you would look at to assess the functionality of whatever organs you are trying to get. And then once you believe, or you have come to the point looking at the heart again, measuring troponins, doing all of the things that you would expect would be done. Once you have determined that the organs are now reanimated to a point suitable for transplant, perfusion ends. Perfusion ends. I am so sorry I'm taking so long. Please forgive me. Perfusion ends, and the organs are clamped, and you start your cold ischemic time. Everything is flushed, removed, packed in ice, taken to wherever it's going to go. Then the implant begins.
Nothing to worry. Carry on. You are a very interesting topic. So nothing.
I am so sorry.
No. Please carry on. Please carry on.
Please forgive me. And then the implant begins, and there's a second warm ischemic time, which is just during the implant procedure. And then eventually you have the now transplanted native circulation taking over for the organ, and everything from that point in time becomes that patient's organ, and the post management of that process takes place or begins. So this is what NRP looks like, and this is a really good slide to have, and it's applicable to any organ. The only thing you would change is this section here, depending on what organs you're going for. You know, that was my last slide. So we have Looney Tunes, and we have a winner. Okay, so I don't know where y'all's politics are, but I'm from here in the United States, and I voted for Trump. So nice. I'll just tell you that. Okay, I had to throw that in there. You know, I'm a red, white, and blue American, guys.
Oh my God.
I am. I love my country. It's not perfect. We do a lot of stupid shit, but it is my country, and I do love it.
Very nice. So now,
do you have any questions?
Joe, before the questions, small token of appreciation for you. Thank you so much. The words of appreciation. Thank you so much. Really interesting, skillful, informative presentation from your side, and it will make us such difference in our lifestyle. Especially, we are looking forward with all the lung, heart transplants centers, and we want the person who have the experience like you, a huge experience. Like I can say, the father of the Perfusion, Joe, you the one who started the conferences, and you involved in the Perfusion uh, enhancing education knowledge. So this presentations is some mind blowing, remarkable, really fully fruitful. And I'll going to open this forum for the questions. So we have so many participants here, like a Franklin from the US. He's the perfusionist nurse. We have Naranjan from India. We have Dr. Chanda from Pakistan, and so many people. Rana Shabazz. So the forum is open for question to the Joe, please.
Absolutely. Then thank you, Ijaz. Thank you very much.
Thank you, everyone. My name is Franklin. I think I'll go with the first question to
Hi,
Joe.
Franklin.
Hello, Joe. Um, since you mentioned that you use high negative pressure whenever you are doing this normothermic radial perfusion, and your pressure go to like minus 140
Yes. Hey, Franklin.
millimeters of
Franklin, could you do me a favor? Could you mute your computer? Because I'm hearing when you talk, I'm hearing you, and then I'm hearing it back again.
Okay.
Now it's clear. Now it's clear.
Okay. I was talking
Much
about
better.
the high negative pressure.
Yes.
Are there adverse effects that come into the circulation just because of that high negative pressure that destroys cells? Or if that's the case, do you do blood transfusions, or you don't care about that aspect?
No, well, of course I care, but you have to remember that your reservoir is acting as both your venous, but that vacuum is also being used for suctions. So everything is coming into it. You don't have any separate roller pumps. So they don't, the venous side is not really going to see the negative 140 because the suctions are also attached at the same time. So if you do cases with normal VAVD, you have your negative pressure at either negative 40. I do my cases at negative 70, but I know a lot of people don't like it that high. They prefer it to be a lot lower than that, but I like mine higher than lower. Unless I'm getting a lot of chatter or something like that. And if you start seeing that with this, you can also reduce it a little bit. But everything is coming into that reservoir. Your two pump suckers, you have a drop sucker and you have a like a wiggly, and you have a Yankauer suction, a traditional regular sucker. And then you have your venous line coming. So you're probably only at about minus 80 to minus 100, maybe even less than that, on the venous line because of all the two other ports that are open, those 2/4 inch lines. We don't have any issues. I run my regular cases with, like I said, with negative pressures of negative 70 on any given day, just my regular cases. And I believe my outcomes are quite good. So I don't see the issue of, I have not experienced that issue. Now, I wouldn't put negative 140 by itself. I think that would be excessive, and I think you would probably collapse the venous, the SVC or the IVC into the cannula. But as long as I'm not seeing any chatter on the NRP cases, you need the negative pressure to be that low in order to accommodate the suckers being able to work at the same time your flow. Because sometimes you're dealing with really crappy volumes on these cases. And if you aren't careful and you don't have your vacuum high enough, and they start manipulating those suckers, the level in your reservoir can change dramatically and your flows can change equally very quickly. It's like I said, it's a very hyperdynamic environment, and one person can do it, but it's challenging. It's really hard for one person to do these cases. You really do need two. Did
Thank
that
you for
answer
that.
your question or no?
Yeah, it did. Thank you so much.
Yes, sir.
Joe,
Where do you work, Franklin?
I'm actually at Anova Fairfax Medical Center here in
Oh, okay. And it's in
Austin.
Virginia, right?
Yes, it's in Northern Virginia.
Yes, yes. Are you working as perfusion? Or are you working in nursing? What are you doing?
I'm currently doing ECMO. I'm an ECMO specialist.
ECMO, very good.
Yeah.
Excellent. Good for you. We're hiring ECMO specialists. You should give me a call.
Thank you.
It's a lot warmer here than there.
I know.
It's more like being back home.
I know. All right, I'll consider that.
Yes, sir. Thank you.
So, Joe, the questions, as you mentioned about the time of for the NRP and for the DCD, you're using the mini circuit instead of the ECMO circuit. So my suggestion, as you're using like a WAD for to keep the negative pressure around 150 millimeter per mercury. So instead of using the WAD, can we go with the like a centrifugal pump instead of the roller in the?
Oh, I don't think that. No, that would be very unwise. It's too much. When they do these cases, they there's not infrequently does there end up being injury somewhere. You'll have air everywhere, and if you're using a centrifugal pump, kinetic assist will say, then you start getting air and you have a big problem, especially when you get competing organizations in there doing these cases. Transmedics is there to get the heart, but we're going to be NRPing for the liver and the kidneys, and the two teams never work very well together. And somebody, cuts the clamps the inferior vena cava and cuts it to take the heart out, but they don't bother with the azygos. And the next thing you know, you've got air everywhere. So you really have to vacuum is the only way to do these cases. You cannot do them with kinetic.
Thanks. So the good. So we have to go with the roller pump with the gravity and with the WAD.
Yeah, I would use a Neptune. You want to have your own independent vacuum source, and you want that to be just yours. No one else is allowed to touch it. And because if you don't do that, you will definitely not have very positive experiences. It will be very frustrating for you.
Thank you. Any other questions from the forum?
Doesn't seem so. I want to tell everybody again, thank you so much, Ijaz.
Joe, there is a Naranjan
Yes.
question. Please.
Yes.
Hi, Joe.
Yes.
Hi. This is Niranjan from India.
Hello, Naranjan.
Hi. I've started my own company, Explore ECMO services. I'm doing all over the world, like ECMO initiation and transfer. It's a new thing I've taken in a personal interest, and I came back. I was working earlier with Ijaz, and we are colleagues, ex-colleague. And I came back to India, started my own company, doing something different. The teaching ECMO program, call kind of things, where heart and lung transplant and organ retrieval kind of things. And anyway, because nowadays I'm not much doing with cardiopulmonary bypass cases, much an interest in ECMOs. It was anyway good, presentation, and really it was very good, informative. And sorry, I joined late. Actually, I could not join. I was driving, and thanks for time.
Don't worry. You didn't miss anything, Naran. Anything you don't know. If you've done all of that you said,
yes,
you probably could have given the lecture.
Yes. Thank you, Joe.
Sure. So, what did you have a question in particular?
No. Just I got because nothing to do, no question.
Well, listen. I mean, of course.
Thank you for this. Yeah.
Yes, I would highly recommend all of you continue to collaborate with Ijaz, and Ijaz knows how to get a hold of me anytime that he wants, and happy to collaborate with this group. I know you have your the book, and Ijaz. I don't know how many times I can say it. I don't want it to sound like I'm just saying it
for no reason.
Friend since many. But you're just so incredibly so incredibly dedicated, and everyone needs to really, I think, understand and appreciate that, because I know how much work this takes. And everybody that's here on this call, it's a Saturday, you all could be doing something fun, except for Rayhan. Rayhan doesn't look like he ever has fun. Rayhan looks like it's all he ever does is works. In fact, I think that hat he's wearing is permanently affixed to his head.
Yeah.
Yes, may never come off. But it was a pleasure. It was such a pleasure.
Joe, you know my nature. I'm fixed with the family.
I see that. I understand that. And you have your family in it. That's what's even more beautiful.
Yeah.
Yes, I heard that when your daughter, when your wife gave birth to your daughter, she had a tubing clamp in each hand.
Yeah. True.
Okay. All right. You guys enjoy your Saturday and the rest of your lectures.
Thank you for your time, and all of the participants who's present in this session. I really thanks all of you. You will all get your certificate soon, and we'll share among the group. Once again, thank you so much, Joe.
Bye-bye.
Thank you, Joe. Thank you, Jah. Thank you, Sinja. Bye-bye. Good night.
Thank you, everyone.
Bye.
Bye.
Thank you.
Bye-bye.
Bye.